to get started here. Let me just pull this over. Making a full screen here. I'm getting better at tech, I gotta say, but still not the best. All right, how's everyone doing today? It's a beautiful day here. I'm in Colorado, and we still don't really have very much for snow if you're thinking about coming here to go skiing. Can't recommend it. It's just been a very warm winter. I think it's like 65 degrees today or something crazy. Yeah, just not normal for February 6th, you know? I would love to see a big snowstorm push through here, but we'll see. And I love skiing, so I'm a little partial to that. All right, I am going to share my slides for all of you, and we have some exciting stuff we're talking about today. I am not a geriatrician, but if you work in primary care, because our population is really aging, you're going to be working with folks that are older. And if you're getting ready for your boards, then you know that geriatrics is a highly tested thing. And the reason why I think our board exams are doing that is because they know that's a population we're going to see a lot of, and they want to make sure we're very competent in caring for an aging population. And I love my working with my patients that are a little bit older. I feel like I learn a lot from them. Um, and I find that it is a population that's very stigmatized, and sometimes we can minimize their symptoms, attributing a lot of things to just being, oh, it's just because you're older. And I think when we get into that mindset, we misdiagnose people and we miss like major things happening. I can tell you, a lot of some of the screening stuff we stop, or the USTF. Um, has stopped recommending certain like cancer screenings, right? And I feel like maybe we'll eventually start adapting some of those and really saying like, well, we're actually going to continue that screening if we think that they have 10 more years of life or something like that. And so an example that I give is a woman that I took care of, and she was like 85 years old, and she had stopped getting breast cancer screenings, because that was the recommendation at probably I think we stopped, she had stopped them before I started working with her. So I think she stopped them around like 75, even though she's like pretty healthy. And when she came in to see me, I did her annual exam. And if any of you are aware with Medicare, Medicare actually in their annual wellness exam doesn't include a physical exam. And that kind of blows my mind. And like lab tests and stuff, it's kind of crazy. You have to have diagnosis codes. And so if you have somebody who's relatively healthy, you're given like 15 minutes to do their exam, and it's all paperwork. So it's a little bit bizarre. I don't quite understand the rationales behind all of that, but I still continue to do physical exams. And in this woman's case, I did a breast exam, and she was like, wow, I haven't had anybody do a breast exam in a really long time. And I said, well, I think it's worth doing. And sure enough, she had a lump. And she was healthy enough that we actually underwent, she had a lumpectomy, turned out to be cancerous. Didn't need chemo or anything, but they did cut it out. And would have that ended her life? I don't know. We don't know. But I'm just saying, like, we can normalize things. We can take some of these generalizations to our patients. And that if we don't have an individualized plan in place and we're not thinking a little bit outside the box, we can miss things. And so that's kind of the takeaway that I want you to have today is like when you're working with patients who are a little bit older, be aware of any biases that you might have or stigmas or an over normalization of a condition because of their age. That is just doesn't feel fair, right? To you, I'm sure. Also to the patient and their families. So, just a little something that I always want to just mention at the very least. Okay, what happened to my slides here is the question. And I hear, okay, no. Hmm. Sorry, guys, I lost my slides on my computer. Okay, well. just going to come over here. Sorry, one moment. If you guys have any questions, is the chat, let me add this, make sure that the chat is chat settings. Sorry, if you want to talk, you can use the Q&A. You can also, hopefully this is totally, everyone can use the chat. Everyone. Okay. Um, can you just, somebody put something in the chat, just make sure that we can see it. Can you type in here? I want some interaction today. I'm doing lots of test questions for you guys. So if we can get some good interactions, that would be really helpful. Awesome. All right, where are you guys joining from? Let's see here. Missouri. Awesome. Where else? Okay, sorry, I'm just looking. Florida, Georgia. Awesome, you guys. Okay, one second here. Let's just restart presenter view. Okay. Moving this over here and this full screen. Okay, I think we're good here. So just that was kind of my little soapbox when we're talking here. If you guys have any questions during this, go ahead. I have the chat open and I'm happy to talk about our objectives, just really talking about what's normal, what's not normal, when we're thinking about these things and answering some board style questions. Okay, so that's what we're doing. And why does this matter? We kind of talked about that. It's the it's the highest utilizers of our healthcare system. So it's really, really important. And sometimes things don't present very typically. So we in older people, like a UTI, as I feel like you should know if you've done school, it presents differently in elderly people, and their symptoms may be very, very different. And so it's important to understand how the body ages and how things will present in those people. So, when we think about normal aging versus pathological aging, I think of normal aging in this kind of more gradual, happening to both sides of the body, pretty predictable, and doesn't impair your basic function. So, if we're having functional impairment, that's not normal. We've all seen the people that you're like, ooh, I want to age like that person. I want that to be your baseline when you're taking care of your patients. Okay. If anybody's not aging like that person, like you want to age like, oftentimes there's some sort of pathological component and we need to be paying attention to that. Okay. That's just, we know that the body slowly, the cells start to just not reproduce at the same rate, and we have degeneration of cells. And is it a telomere on the DNA? I don't know, I can't remember all of it. Shrinks, and so we're like losing our ability, and that's what causes our aging. And they're like trying to figure out how to circumvent that, right? We have all these people that are studying the longevity medicine and trying to keep us healthier. I can't remember that like tech billionaire who, I think it was a Netflix thing, who basically takes all these supplements and has this really intense lifestyle to try to live. I mean, he wants to live forever. I think he gets like I don't know if any of you saw this. He gets plasma from his son. I don't know, something crazy. But aging, lots of people are trying to defy their odds and live for as long as possible. But at this point in time, we don't know anything that's like really great at slowing down aging other than exercise, sleep, stress reductions, right? Exercise being so, so, so important. And so I always tell my parents, like, hey, even if it's like 10-minute walks, that's better than nothing. Being sedentary is probably one of the worst things for aging. And then poor diet, obviously, like our body needs good fuel, sleep, super, super important. And so when you're having conversations with patients, I want you to talk with them about that. Socialization, really important for the memory, right? So all of these things do matter. Okay, we're going to start off with just this little every single area, we're going to start like this. Okay, Mrs. L, 72-year-old female, retired teacher, reports forgetting names occasionally, misplaces her keys, manages finances independently, and has no personality changes. Is this normal aging? You know, forgetting people's names, misplacing keys. Is that normal, or do you think there's something pathological happening here? You can go ahead and answer in the chat. Any ideas? She's able to do her finances independently. Personality remains the same. She was a teacher. Cool. Very cool. Normal. Anna says normal. I agree. I think this is really normal. I forget where I put my keys. I forget people's names. That's pretty normal, but we don't want to like always compare to ourselves. That's not a good practice. But I would agree. This is normal. When we think about things that are normal aging, processing speed time does decline. Okay. We might have some short-term memory lapses. That's normal, right? You have a little bit trouble finding words, but overall, your judgment's good. You're able to complete daily functions. If she's managing her, balancing her checkbook is what a lot of my patients will say. That will change as times go on, but able to manage finances and pay bills and do all of that higher executive functioning type tasks, I'm pretty reassured by that. Now, if I have a patient who, I have a mailman who we did diagnose with Alzheimer's disease, and it's a devastating diagnosis. Yes, it was very, very sad. Um, and we're using tools to try to prolong his memory as much as possible and keep things intact and let him do his activities of daily living. That's what ADL stand for, as much as possible, right? And so his task, his trick right now is that we have a notebook that he's writing down things so that he doesn't forget. So, and he remembers, luckily enough, still to pull out his little notebook and refer to that at this stage in his disease. Now, eventually that will probably go away and he'll even forget to look at the notebook or forget how to maybe write. Words would be very difficult as the disease progresses. And he's relatively, I mean, he's otherwise very, very healthy. So this is really pretty sad. But what we see is that folks with some sort of pathologic memory or cognitive decline is going to be more significant, more severe. So, like getting lost in familiar places. And we've all parked our car and forgot where we parked because maybe we were very distracted, highly anxious, or something going into whatever we were going to do. And so you come out. I've been like talking on the phone and then just like, I have zero recollection of parking my car and I have no idea where it's at. That does happen, right? But this is more significant. So we want to think about this like, and there's a lot of masking that's going to occur in the early phase of some sort of memory loss. And so patients can be very, very good because they don't want to face this. And the brain is really good at protecting. And we use what's called masking. So it's like kind of making up excuses as to why maybe they got lost. So maybe just we've all seen that. Maybe starting to like lack on hygiene a little bit, right? So not showering as regularly, maybe not changing clothes, things like that, where there's just some like little hints that there's something else going on here. Now, personality behavior changes definitely, and that's something coming from the family. So if in fact your family is worried about these things, then we're going to do something about it. We have our different types of memory uh, testing that we can do. Do you guys like what's your favorite test that you perform in the clinic if somebody comes to you and they say, I'm worried I have dementia? What are you seeing used? What do you prefer to use? I'm thinking of the MOCA, the mini mental, the slums test. I don't know if you have any others that you like. Me personally, I like the slums because it takes into account level of education. So if somebody perhaps didn't graduate high school or they're a college degree or a doctorate degree or something, that level of like maybe how they would perform on that test, the slums test takes that into account. And so that's why I really, really like that test. Now, in early stages, those are not going to be the best testing that we do. So you have to really rely on what people are telling you and try to determine, is this normal or is this pathologic and where should my level of concern be? Now, what do we do if there is some concerns for pathologic aging? We're going to look for a diagnosis as soon as possible through so if you're getting any sort of screening that you're concerned about or symptoms that you're concerned about, you're going to be referring um, on to an upper level of care, so neurology, neuropsych, for additional testing and evaluation. brain MRIs can be helpful in diagnosing things like dementia. Um, but I think it depends on the stage, right? So if it's very, very early and we're having very mild cognitive changes, an MRI could still look somewhat normal, but that doesn't mean we don't start having conversations. And I always address it with my patients as what can we do to prolong that memory? So like with this patient, writing things down, really triggering his memory throughout the day and really working it. We schedule everything that's really important in the morning when the brain is the sharpest. We really focus on getting good sleep if we can, because we know that sleep is critical to cognition. Good nutrition, obviously, as well. And then other things people love to know, what can I do to keep my brain alive? And so, or my brain working really, really well in my memory. And crossword puzzles, all of those things that neurologists say tend to be helpful. I'll go ahead and recommend ballroom dancing. I don't know if you guys have heard that, but dancing and socializing is so important. And then I always check people's hearing and making sure that if, in fact, we have some hearing loss, we need to address it because we know that hearing loss can is associated with cognitive decline, and so that's really, really important. Okay, um, for recorded sessions on our Facebook and YouTube accounts, you should be able to find everything posted on there. I think it takes a couple of days, like maybe they edit out some of my hums and haws. I'm not sure, but they do go to YouTube. All right. Which finding in an older adult is most consistent with normal aging? Difficulty balancing a checkbook, forgetting appointments despite reminders, slower recall of names with later retrieval, or repeating the same story multiple times in one conversation? Which one's A, B, C, or D do you guys think is consistent with normal aging? What would we, somebody tells you that this is happening to them, what would your response be like? Oh, that sounds pretty normal. Any thoughts? Yes, I agree. C, so slower recall of names with later retrieval. That to me seems pretty normal, right? But if you can't balance your checkbook, we're talking about executive functioning starting to fail. That's not normal. Now it's common, right? And I want to distinguish things that are common and disease states that are common with aging versus normal. And so, getting to the point where balancing a checkbook is difficult is a pretty common phenomenon that happens with aging. However, there's something pathological happening in that person's brain. And we know that there's people who live to be like 110 years old and still have executive functioning. Hopefully, that's helpful to understand. My sister, her father-in-law, he's Italian, and he's a family practice provider, physician over in Italy, and he was the doctor for, and I can say this because it was all over the news, like BBC and stuff. He was the doctor for the oldest living person at the time. She was 100 and like 15 years old. Her name was Anna something, but his name's Dr. Bava, B-A-V-A. If you want to look it up, it's kind of a cute story, but she ate a raw egg every day, and that was her like what she said kept her alive for the longest time. I'm not sure I would recommend that, but it's kind of funny. Okay, moving on. Mr. R, 80-year-old male, blood pressure 148 over 62, no chest pain or dyspnea, active, walks daily, isolated systolic hypertension present, normal aging or disease. What do you guys think? Is it normal for blood pressure to kind of creep up? Okay, disease. I love this question. Okay, so it's actually normal. So we have arterial stiffening that is a normal aging that happens as we get older. So what's very, very interesting about this is that just because it's a normal aging doesn't mean we ignore it, right? So just because, somebody has systolic hypertension, which we say is probably likely due to age and arterial stiffening, doesn't mean we ignore it. We're going to still treat it, right? And that's the key differential here. So I want you to think about things that even if they are normal aging, doesn't mean we ignore them. We're going to address those symptoms and we're going to address the issues, because what can normal arterial stiffening and increased blood pressure lead to? later on if we don't do anything about it. Why do we care so much about this? It's the target and target organ damage, right? So that's why we care. And so we're going to do something because it can lead to a pathological finding, enlargement of that heart, right? Kidney damage, retinal damage, vascular, just overall arterial damage, right? So that's why we care about it. But the actual stiffening of the arteries is a normal aging type presentation. Okay, what's not normal? Orthostatic hypotension with symptoms, heart failure, angina, syncope, those things we would consider to be abnormal in a cardiovascular patient. All right, which cardiovascular finding is expected in normal aging? A diastolic persistently above 90, resting tachycardia, a widened pulse pressure, or sudden onset atrial fibrillation? Oops, awesome. All right, so we're going to tie this back to that arterial stiffness. The wide pulse pressure is actually the difference between your systolic and diastolic, and it gets larger, often over 60 or even 100, indicating those stiff arteries that occur in older adults due to that less elasticity of our vessels, and it's making that heart have to work a little bit harder. So the correct answer here is C, which is kind of crazy, but this is where we're kind of going into. Okay, now creatinine, renal system. What do you guys think here? Okay, sorry, one second. Let me pull this over. So we have a 78-year-old creatinine 1.0, EGFR 48, no urinary symptoms. Is this normal or is this pathologic? What do you guys think? Normal, that GFR, that's what's sticking out to me, a 48 GFR, 78-year-old. All right. So that the answer is actually that a reduced GFR is actually pretty common and normal. We're going to see that it declines. Why is this so important? Because we really need to take care of the medication that we're prescribing for elderly people. And that's why you're going to constantly see, once again, that even though a reduced GFR is expected, we're still going to treat it, right? And so normal change doesn't mean benign. We still are going to do something about this GFR. So, what are some things that we might consider to address this decreasing GFR in this patient? Let's say that's kind of the only finding that we see. Do you guys have any ideas about what might be a beneficial type of thing to consider? So as we're aging, the renal mass actually decreases, which is what kind of leads us to that reduced GFR a little bit. More water, more fluids, avoid necessary meds. Absolutely. I love those answers. Salt intake, right? Like, let's talk a little bit about that. Let's make sure that blood pressure is under control. If blood pressure is not under control, what are we going to add for this patient? What medication would you prescribe as a first line treatment for some, let's say even mild? Let's say their blood pressure's on average like 135 over 86. All right. Even though they're 78, that's technically under the 140 over 90 guidelines that we see in hypertension in elderly people. But in ACE or an ARB, absolutely, that's what I would consider. Even if it's a 2.5 or a 5 milligram dose, I'm going to add a little bit because I might be able to get a little bit of renal protection from that ACE or ARB. SGLT2s, if there's perhaps some like hyperglycemia occurring in this patient, can be very, very beneficial. What medication are you going to be concerned about continuing? Let's say you have a patient who has diabetes and they are continuing to have their GFR decrease. What is a common medication that we prescribe that we need to probably discontinue? Any ideas? Jardiance? Nope. So that's renal protective. That's the SGLT2. It's a common medicine that we use a lot, but it's a renal clearance medication. We have to be really protective. So I always check people's GFR before prescribing this. It's metformin. Okay, so when you're prescribing metformin or somebody's on metformin, maybe they've been on metformin for 20 years, but if their GFR is slowly decreasing, we need to evaluate, is it time to pull that medicine? Okay, just a quick kind of FYI. Okay, which lab finding is most concerning in an older adult? A GFR of 50, creatinine of 1.1, trace proteinuria and dipstick, or a stable GFR of 44 over the past 5 years? Which one of these would cause concern for you? Absolutely. Good job. Yeah. Protein in urine is never normal. We need to figure out why our filter is allowing us to get protein through. There's some sort of breakdown in that glomerular filtration, right? The nephron is allowing protein to come through, which it should never be spilled out. We need to keep that protein in our vascular system. All right, multiple musculoskeletal. Loss of height. We have Miss S, 76-year-old. She's lost 2 centimeters over the past 2 years. She has mild kyphosis, no pain, no fractures. Normal aging or pathology? Normal. I agree. This is normal. So, what we see is the sarcopenia, which is loss of muscle mass. Very, very, very common, especially in women. And so, the education that I have starting at 35 is the importance of resistance training, making sure during that menopause transition, that's when we're going to lose the most bone and muscle, and we are going to put on fat, about 1.5 pounds of visceral fat, well, fat in general, and a lot of visceral fat per year after the age of 50. So if you think about that, we're losing muscle mass, we're losing bone density, and we're putting on fat. We are setting ourselves up for metabolic disease, right? And so we need to have conversations not about being thinner as we age, but what we want to do is be stronger. And so that should be the messaging that you have with your patients, making sure we're getting plenty of protein intake. That can be something that's compromised, especially if we have dental issues. So something you want to address if people's teeth are not well, and if they need replacements or dentures or something, or if they need supplements for protein, we need to be having that conversation because of the impact on our musculoskeletal system. We also have things like osteoporosis that's happening. We're seeing a lot more women being started on menopause hormone therapy that can help delay or prevent osteoporosis. But those women that, that we have an entire generation of women that were not really given any sort of menopause hormone therapy. And I think we're going to see kind of a big shift towards osteoporosis in the next like 10 to 15 years because of that. So something to be considered. We have our bisphosphonates. Make sure you're comfortable with those. Make sure you're comfortable with understanding that. But when we think about normal aging, losing a little bit of height is normal. I'm attending a conference with Stanford actually this whole week. And with resistance training, there is a study that they did with resistance training in like 80-year-old women. They actually saw an increase in height with resistance training. So that shows you how getting a little bit stronger helps us actually stand up straighter, right? We're not getting back that disc height that we see that gets lost over time. But what we get is that normal kyphosis back to a little bit better posture, which then when we're standing, we can actually do it. And in Italy, if you're back, I can't remember exactly what it is, but they have women stand up against the wall. And depending on their degree of how far their head comes out, they can diagnose, that's how they think about osteoporosis and stuff like that, based on how they look when they're standing up against the wall, which is quite fascinating. All right, we're at risk for fractures. That severe kyphosis, we're really hunched over, right? Back pain, compression fractures, stuff like that are the things that we're going to be on the lookout for. All right, which of this finding suggests pathology rather than normal aging? Gradual decrease in muscle mass, loss of height over decades, sudden onset of back pain after just bending, or decreased flexibility. What's normal or which of these is pathologic, do you think? Yeah, what do you think's going on? The answer C is correct. And what we think happens in this concern here is actually has to do a little bit with compression fractures. And if we have severe osteoporosis, we're at risk of compression fractures. And that's something we are always really, really on the lookout for. All right, this is my last slide today. It's just talking about polypharmacy, and this is really important. So when I see my patients that are older, they're often on a lot of different types of medicines from different specialists. Sometimes there can be drug-to-drug interactions that maybe that specialist wasn't given the full information of their current medication list when they were prescribing it. And I find my job as a primary care provider is really to be the orchestrator, right? So, in making sure that whatever this specialist is prescribing and this specialist is prescribing, making sure the patient is taking it as prescribed, which is so, so important. I have them almost every time I see them, I just tell them, hey, if they're on a lot of different complex things, I say, bring in all of your medications, all of your supplements, anything that you're taking. I want to see it every time. And we get really fast, and my MA can use it to put it into the medical record and update any dose changes. And then I can also have a patient, like I have them bring in whatever list they use to keep track, and then we can update that in real time. It's so important because there's so many people who are misusing their medications just because it gets so complicated. Take this medicine on an empty stomach before, first thing in the morning, and then take this one with breakfast and take this one at lunch. And, it can get very, very confusing. So I try to keep things as simple as possible. Make sure if there's something that they don't need, can we deprescribe? Always ask yourself about deprescribing and is it possible? Is this doing anything? And is it, there's a big discussion around statins in older people. Um, it depends. This is a nuanced conversation, an individualized plan of care. Depending on how healthy they are, is the statin really doing too much? It's always a conversation. I don't deprescribe those unless somebody is pretty advanced in their aging process or a diseased state in which I don't think they have a long time to live, then the statin is probably not doing too much, right? And if it's, complicating things and if it's having any sort of, I mean, the the harm and the side effects from statins are pretty minimal usually, and we can kind of counteract those um, with like a CoQ12 or 10 or whatever it is can be very, very helpful. Um, Most important, though, is to understand always checking people's renal function and asking yourself, how is this drug metabolized? Is it through the liver? Is it through the kidneys? Do I need to decrease the dose based on this person who's sitting in front of me? Or do I need to completely get rid of it because of any sort of advanced liver or kidney disease? Okay. And then drug to drug interactions. What are people prescribing? Are they working? And it might be a phone call with a specialist. Hey, I saw that you prescribed this, they're on this thing. Is there any way we could maybe switch it to something that's more compatible? So you are kind of the director of the orchestra, and that's what I think of our role in that primary care setting. Here is an updated vaccine schedule for you guys for elderly people. I do recommend these vaccines. I know there's a lot of changes happening around vaccine recommendation. Most of the bodies that I follow, so like pediatrics, ACOG for like pregnancy related recommendations along vaccines, and the Geriatric Society. I think all of those societies have maintained the same recommendations prior to the recent updates from CDC. And so I still recommend what those bodies, so like American Academy of Family Physicians, AFP, I don't know. They haven't changed vaccine recommendations. And so I recommend following those at this time as well, but do as you feel fit with that. Most important key takeaways: aging causes predictable physiologic changes, disease causes dysfunction. There's subtle differences here. Okay. Um, just because it's a normal aging process doesn't mean we don't treat it. And that's kind of the key thing that I want you to take from this today. We see that, mislabeling leads to harm. In either over like treatment or missed diagnoses. So have conversations with your patients. I have some really good questions here. Unfortunately, we are out of time. Um, Gosh, I put in so many good questions at the end that are like a little bit more board focused. I'm gonna just put these here real quick, um, so that people can go on later and read these questions. And you can pause it and you can just go practice these questions if you want to on your own. Okay. Um, Awesome. And as always, we have lots of great offerings at Archer. We're constantly working to improve what we have. So make sure you're following us on Instagram, on TikTok. We try to do some lives there as well to answer questions. And if you have any questions, don't hesitate to reach out for us. Hiva and I are doing the 1 day live review. Our next one is February 17th, I believe, or 18th. Is it? It's the Wednesday. Is that the 18th? Yeah, I got a lot of stuff on my plate. But it's Wednesday, the Wednesday after President's Day weekend. So um please, if you are getting ready for your boards or if you find that that might be helpful in guiding where how to study for your boards, go ahead and sign up with us. And otherwise, have a wonderful weekend. I hope things are going great wherever you are. And if you need anything, just reach out to us. We are more than happy to help. Good luck. And just remember, try not to stigmatize older people and really take their concerns seriously and enjoy working with them because, wow, the wisdom that they have is so fun and it's just kind of some of my patients are probably those that are 80 plus. I had a patient who recently passed away. He lived to be 95 and what a joy it was to see him and he's greatly missed. So enjoy that time with those patients. And if you need anything, you guys just reach out to us, okay? Let's see, let me just check the chat. Looks like we're up to date. Nobody put any questions there. Have a wonderful weekend and good luck wherever you're at in your